This conference will now be recorded.
It's Tuesday, July 9th, 2024. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators, not Len Sierra tonight, but John Antonucci and Rick Davis, the founder of AnCan. Medical issues make up most of our conversation, but as always, nothing you hear tonight will be medical advice. Funding for this meeting comes in part from companies that believe in our work and have provided sponsorships. We make it clear to them, and we'll make it clear here, that our gratitude doesn't necessarily mean our endorsement. We continue to call them as we see them, and they still support us. The companies are Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Helix, and Blue Earth Diagnostics. So I take it there are no newcomers tonight. Okay, so we can go straight down the list. And the first plus mark on the list belongs to Mark Balance. Come in, Mark.
Well, hi, I just wanted to check in, see if anybody's had any thoughts about amphetamines. I've been struggling ever since my recurrence back in November to get back on balance, and the fatigue and everything else was worse than ever. And I was on 120 milligrams Xtandi, and I had to go down to 80 milligrams. And then I tried switching over to darolutamide, and it got a whole lot worse. So I went back to the Xtandi and stayed on 80 milligrams for quite a while. But recently I went back up to 120 milligrams, and I seem to be tolerating it, but the fatigue is really there. And my doctor prescribed Adderall, and it seems to really be helping. I'm just a little wary about taking amphetamines. So I wonder if anybody has any thoughts or any experience.
What are you worried about?
I don't know. You just hear all these bad things about amphetamines.
I mean, if you have
They get abused easily.
If you have no heart problems, no high blood pressure problems, no issues along those lines, I don't see what the problem is if you're asymptomatic. And if it makes you feel better, what's the problem with taking it?
Okay.
Well, that's provided that you don't get in the habit of increasing the dose if they don't work quite the same that you'd like them to after a time.
Well, they don't. But I've resisted trying to increase them. And the doctors recommend that I take 2 days off a week. And I notice the difference the days I don't take them, but for the most part, I'm doing better. The best thing is I'm able to get to the gym pretty regularly now, which I was really having trouble with. But I have an Adderall at 5 o'clock, and I get to the gym at 6 o'clock, and I'm doing better.
That's 6 o'clock p.m. p.m. you get there?
No, a.m. Everything's in. No, my day's over by 6 p.m. I just want to know if there's anything I should be looking for or worried about, but seems to be going all right.
So it's interesting you raised this, and I don't know if you saw in the reminder this week, but I put a link in to the updates, the ASCO update on managing fatigue. And the consensus is to avoid medication where possible. And I actually mentioned that back in the day, I used to know a bunch of guys who were prescribed Ritalin, and it did, most of them, it seemed to help, not a huge amount, but a little amount. But I haven't heard of anybody taking drugs for a while. And then you mentioned it today, and it's probably the first time in 2 or 3 years that I've heard somebody say that they are taking and have been prescribed. So I don't want to say it's controversial. I do want to say that it's not preferred. The ASCO guidelines suggest more integrative methods like obviously the exercise, although as Mark points out, you've got to be able to get to the gym. So you've got to do something to get to the gym, and then they definitely talk about CBT, which maybe Dr. Jack can elaborate on, and then things like Tai Chi and Qigong and yoga, and the one that I particularly liked, and unfortunately, I don't think Dr. John is with us just yet because he might know more about this, but moxibustion. I kind of like that word, moxibustion. So I'd be interested if anybody has had any discussions with their doctor about managing fatigue and what's being suggested. Don't all talk at once.
How quickly did it you that it, you would need an increase? How quickly? How long have you been on it? I guess.
2 weeks, I guess, and it's still working.
Okay.
You know, it's interesting. I take one day off and I notice, and then the next day I go back on and I notice. But and it's not my regular med that prescribed it. It's my palliative care doctor. But it's making life better for me. So
Does it cause constipation at all?
it has not. I mean, I've always had some constipation ever since my radiation 5 years ago, but the drug hasn't made anything worse.
Well, we're putting kids on it, so
And
Well,
there's no,
Adderall is basically for kids with ADHD or whatever. But
right.
They have a paradoxical effect, and they, don't have the same, kind of hyper effect that we have if we don't have attention deficit disorder. So you got to look out for that. The amount of anxiety you start feeling, the insomnia that may kick in, the nervousness, the jitteriness, the agitation, all of those things can occur as side effects. But I think the overall thing is, at this stage of your disease, you got to do what makes you most comfortable, and if it's making a huge difference in your energy level, I certainly would, even though it may not be endorsed by ASCO or they're not anti, but they're just not for it. They don't endorse it. But I think it's useful for palliative, treatment. Most of us are getting it. As long as you can take it and you don't have the heart and the atrial fibrillation and any arrhythmias.
We're watching for all the
skip beats and all the other things that can happen with that
Yep.
medication. And you got the heart's pretty durable. You don't have to be as worried.
Yep.
Anyone else? Is there anyone else that's using it or has discussed it with their doc? Interesting. I mean, when I say back in the day, I'm talking really I'm thinking back around 2010 to 2008 to about 2014, that area there. I probably knew 3 or 4 guys who were on it simultaneously. You just don't seem to hear about it much anymore, and it's interesting to me that it's the symptom management service that is prescribing it as opposed to the medical to the GU med onc. So
Other than the people that are addictive to this kind of stuff. Does it have any other detrimental effects? Burning out adrenals or anything like that? Anybody know?
Yeah, the only thing I know about Adderall is that Adderall is amphetamine. And when I was young and a drug enthusiast, I took lots of amphetamine. Now I've been in a 12-step fellowship for a long time. I know a lot of younger people coming into the fellowship that have had terrible, terrible problems with Adderall. But before they had problems with Adderall, they had problems with methamphetamine. Before that, they had problems with dexedrine and benzedrine in the old days. Speed is speed, and safely prescribed in the right hands, taken in the right amounts, everything is fine. That's why I don't want to get into whatever telling anybody what to do. I would never take amphetamines. But if, like I said, the thing to watch out for, anybody I would say this to, is you said, well, you can really feel it on the days off, and you thought about increasing the dose. If you find yourself increasing the dose or taking those days off and taking it anyway, anything like that, just try to be honest enough with yourself to say, no, I don't know better than the doctor here. And that's actually a real good sign, unfortunately, a bad sign, if you start taking them other than it's prescribed and justifying it. So that's the
Yeah,
only thing I would talk about.
I'm watching it pretty closely, and for some reason, I'm not an addictive personality. I've never really gotten addicted to much of anything. Um, and I'm watching it, and my palliative care doctor, she's great. So she keeps checking into me. She only gives me a 30-day supply and checks in with me before she gives me any more. So I think we're okay.
I want to start taking it before I go to the gym. You're making it sound awful good, but I don't think I'm going to do that.
That's a new Jimmy recommendation.
Yeah, I'll let you know how my workouts are on Adderall. Be ready for the Senior Olympics in no time.
From 100 push-ups to 200.
It's going to go a lot higher than that.
Okay, thanks, Ben.
Thank you,
How
Mark.
do you do with caffeine? How do you do with caffeine, Mark?
I drink coffee. I usually have 2 cups a morning. And if I miss it, I don't even miss it.
Okay, so you're not
Mm.
inclined to be hypersensitive to it. So you're probably, not compounding the effect of Adderall. Some people drink a lot of coffee and it compounds the effect, and they're sort of synergistic.
Yeah, the only caution from the doctor was take it very first thing in the morning so you don't have trouble going to sleep at night.
That was a great discussion. Thank you, Mark. Jeff Markey, you are next.
I don't know, just for a aside, I don't know if everybody read that clinical trial article in the Lancet about taking abiraterone before enzalutamide. Where people have questioned this for a while, and it sort of closes the door on that question. I appreciate Rick having sent that article. I know other people that have been wondering about that as well. I have a friend who, I've talked about this guy. He's been on lutamide off and on for 7 years, and he finally had to stop taking it. And they put him on Orgovyx and darolutamide, and he ended up in the hospital with a sepsis infection and has been extremely sick. He claims that darolutamide messed up his blood counts, and that's what caused it. Now I know that he got an injury with some working on some wood, and not a small injury, not huge, but did need stitches. But I suspect he did not correctly use antibiotics on it and caused an infection, which then. But has anybody else had issues with darolutamide and infections? I've never heard of it. He just wrote me today again about it. warning
One of the,
me,
big,
darolutamide could be dangerous.
one of the biggest concerns I've had about my absolute neutrophils when they get too low, I'm on darolutamide, when it's gotten down to 1.6, I get anxious. And I've been told that's usually not the point at which we get concerned. We get concerned when it's closer to 1,000. Now, if you're going to get an infection, I don't know, if you have to go as low as 1,000, I don't know where he was. He may have been down there close to 1,000 or 1,500, and you get an infection superimposed upon that without having a higher absolute neutrophil count, you could be more inclined to get sepsis or an infection. So it's something you gotta watch out for.
He says his white blood cell count was high, real high, and that is
Well,
what is part of the cause.
well, that's secondary to the infection, but what was it like before he had the infection, his white count?
I don't know. I thought that their white blood cells are what actually helps cure an infection problem, and that a high white blood cell, with what you're saying, I guess, is that a high count means that your body's fighting it harder. So nobody's heard about a problem with darolutamide and infections, or enzalutamide, who knows? I know that my red blood cell and hemoglobin are pretty low, but they're not supposed to be infection issues. They're more anemia issues. Okay.
No, I mean, the one thing that I feel obliged to say, because we've committed to do this, even though this is sort of once removed, is that if the guy feels that strongly, he should be reporting it as an adverse event.
Interesting.
And we have the places to report that on our website.
I saw that.
And in the letter. I promised Dr. Pooja, that if we heard anything, we would encourage people to report. So if he feels that it has had an impact, he should report it, and they'll investigate it.
Okay, I will do that. I will tell them.
Thank you. Thank you.
Thank you, Jeff. Dan Straub, you have the floor.
Great. I have great news to report. I finally got through with Dr. Ferrara, and I'm going to start hormone therapy, Casodex, soon. I got to pick it up tomorrow. I'm getting a Lupron injection next week or the week after, and then she has me on triple therapy with Adderall and prednisone. And I met with Dr. Nasser for radiation therapy. I'm going in for markers next week, and that'll start. He is following, I assume, Rick's recommendation. He said I'll be the first one to try this. They're shortening the IMRT to 25 sessions with 2 sessions of SBRT. So the only question I have is, with IMRT, anyone have advice on the full bladder that they might be recommending?
Ooh. Well, before we get into that, and there's going to be a lot of people talking to you about bladder control, that we'll get into that discussion. It's got legs. I don't want to say I recommended it. I want to say that protocol, that is Dr. Roach's protocol. If Dr. Nasser is not familiar with it, he should definitely reach out to Dr. Roach at UCSF. And Max, probably very eager to talk about it. But he's been using it now for at least 2 years. He started off with 4 sessions. Well, let me back up one. When SBRT was approved for just treatment to the gland, just regular treatment to the gland, it was approved in 5 sessions. Mac always said you don't need 5 sessions, you only need 4. So when he first started treating the high-risk disease like yours, using SBRT as a boost, he did it with 4, and since then he's reduced it to 2. Now, I don't know how many grays in each. I don't know how many grays he puts in the IMRT, but I do know that it's been successful treatment and he continues to treat with that. So the standard, and I see Mark nodding. I don't know if anyone has actually had that SBRT IMRT combination from Mac.
That's exactly what I had. I had 2 sessions of SBRT and then 26 sessions of the other. And that was 5 years ago.
Right. So he's been doing it for a while, Dan. So if Dr. Nasser needs any guidance on that, let us know. I'm happy to open the door to Mac, or Mark can open the door to Mac. Mac knows us real well. And like I say, he was my doctor. He's been my doctor since 2007. So.
The only thing he mentioned is that instead of doing the SBRT first, he reverses it, does the IMRT.
Okay.
Mark, do you think any impact would be from changing it around?
Well, what Mac told me was, at the time, was the standard was to do the SBRT afterwards, and that he flipped it and started doing the SBRT first and said he had better results that way.
My brother got 5 from Roche at UCSF when he had his done last January.
Yeah, but that's different, Jeff. This is SBRT plus IMRT for high risk disease.
Okay.
With
By the way,
boost.
that's not triple therapy. Triple would be if you had chemo, prednisone. It's just 2 double therapy with prednisone and abiraterone.
Mm-hmm. Thanks. And if no one else has any comments on that, there was another question I had about spacers.
Yeah.
Well, let's go back to your bladder issue, because there's a few people who would like to talk to you about how they managed their bladder when they had radiation therapy.
Cool.
I can join in on that one. That was my question tonight. Is getting up 6-7 times a night, hardly getting an hour and a half, 2 hours of sleep. And it was recommended that I control the bladder with solifenacin. Came from my endocrinologist.
So can we time out, George? Can we come back to your issue? We can definitely talk about it, but this is a question for people who had radiation therapy, and how would they advise? What level of fullness were they advised to enter the radiation therapy with? That's what this question is about. Should you go in with a full bladder? Did they tell you to? Did they not tell you to? So when you had your radiation, George, what did they tell you to do for your bladder?
Empty my bowels and fill my bladder as full as possible, so that by the time when the radiation was about to finish, I was almost on the verge of peeing on the table.
Right.
Full bladder. And then I also had the spacer.
So they said medium full. I didn't have to have it real full. And so I just, make sure I didn't pee right before I went in. And then every once in a while they'd say, well, drink a glass of water and we'll wait 5 minutes or something. But usually I just peed 15 minutes before and then went in there and I was fine.
They wanted mine very full, and it was a struggle sometimes. And if I had it full enough, fine. And if I didn't, they'd have to send me out to the lobby where they had nice bottles of water in a big bowl. Very nice of them. And I came in a couple of times, and it was so painful after I finished, because it was just that full. I really could almost not get off the table a couple of times. As I've said before, I'm not kidding. One of the techs was this beautiful woman who assisted me greatly in getting off the table. And it really helped me get to the bathroom without too much pain if I just kept my eyes fixed on her. Seriously, they really wanted it full. It was hard.
Yeah, me
Did you say she wanted it full or you wanted it full or the doctor wanted it full?
Whatever she wanted, I was going to do it. If she said she wanted a full bladder, that was good enough for me. But it's tough. It's tough. If you do too much, the timing is hard. Sometimes the person in front of you takes longer than they're supposed to. Sometimes they have to be sent off to get more in their bladder. The timing is, the whole thing. Every time I went to radiation, it took about 8 minutes, but I was in there for 45 minutes, an hour and a half sometimes, just because the timing is bound to be screwed up. For those different
What time is your appointment?
I think 11 o'clock.
Yeah, I would if I were you, I'd try to get the first one of the day, because then you can get it down to somewhat of a science where you find out the right amount to drink, and you can avoid being in the pain that you can be with unpredictability. I did first thing in the morning. I had to drink 32 ounces. Eventually I kind of got it down to where I could manage it.
In and out before the crowds hit.
Yeah. Did you have surgery?
No. I
So
declined.
you got two sphincters working for you.
Mm-hmm.
That's a plus.
Oh yeah.
I found it very difficult. For some reason, I had also was getting radiated sometimes together with T6 and bladder, and they always had to do T6 first, and that was the hardest. They were really difficult, but I would say I had to take a break and I'd go out, drink more water, wait 10 minutes, come back in. It was quite an ordeal for me. Um, I'm glad I did as much as I did because now I find that I have what I call double tap. It means that now, since that radiation, when I go to the bed, when I go to pee at night or in the day, I pee and then I wait like 8 minutes and I pee again because there's something that happens from the radiation. Only made it like it doesn't hold the same amount of water and I can't empty my bladder like before. So I'm glad that I got away with just that problem. But it was quite a challenge. Not looking forward to doing it again.
In my experience, it was all how full the simulation scan was. So they basically wanted me to replicate whatever I was in the simulation, which was very full. So then in each of my EBRT, it was very full, and so I just used a clamp, and it was a bad clamp, and so I recommend a Lundberg clamp. It's a bit more comfortable.
And that didn't interfere with the radiation?
Not at all.
Where did you happen to get that, Kurt?
Oh, the clamps, they gave me clamps, but they were just bad clamps, that kind of that thick foam clamshell clamps, and so they just gave me one. They actually ended up having two, and so I've subsequently bought the Lundberg clamp just for help with stress incontinence on hikes and things like that. And that's much more comfortable than the clamps that they gave out, which were obviously cheaper. So
The Wiesner clamp is also very comfortable, and they sell them at Amazon.
uh-huh.
They're not very expensive. They probably sell Lundberg there too, I would imagine. They gave me a different clamp at Kaiser, and it was not nearly as comfortable.
Right.
I was recommended the Wiesner, and it really works.
How long can you safely wear a clamp?
2 hours.
It doesn't hurt like hell, huh?
No, you don't clamp it down that tight, Ben. You can make it hurt like hell. You don't need to though.
And you can move it after 2 hours if you, and then wear it longer.
Hmm.
So if there's no other comments on the bladder, how about the the spacer, the the need for the spacer? Dr. Nasser's saying he won't be able to evaluate that until he actually looks at the MRI scans, etc. I'm a little hesitant. I think he really needs to do it to protect the rectum, etc. Any comments?
Well, it's lucky you're not getting your treatment from Dr. Roach because he doesn't like them, he doesn't use them, he's never used them. I don't
Wow.
understand why. Maybe Mark Valens does or anybody else who's been treated on here, but he just doesn't use them. I think the reasoning is that it moves things around and it can change the shape and where I'm not really sure, but I can tell you I didn't get space sore because it wasn't around at the time, and neither did he tell me to fill my bladder or anything else. So, but Mark, why what you're only 5 years out. I'm 16 years out. Why did Mac tell you he doesn't like those the space saw?
I didn't know anything about him. He didn't offer it. I hadn't met AnCan yet, so I didn't have anybody telling me about him. So I was blind about that.
Okay.
Yeah, it's too bad Len isn't here. He has a story. Yeah, Len had gotten one, but it was equivocal. It didn't help him. He ended up with radiation proctitis despite the space sore. But there was a glitch in the timing so that it might not have been done at the optimal time. So it's kind of a Shaggy Dog story in short.
Mhm.
Never
So,
had a spacer, never had a problem.
Hmm.
35 or so procedures.
Good to hear.
Rick,
Thank you.
do you know if there's a guideline about that?
I think it is optional. If I remember correctly, it's mentioned, but it's not recommended. It's not discouraged
Right,
either.
right,
It's
right.
just, I think, but I'd have to go. I'd have to go back and look. To be honest.
I think the success of the spacer is highly dependent on the skill of the doctor who's putting it in place.
Oh, good.
Right.
Say more. Say more,
Yeah.
George.
Well, this was at Duke, and the doctor who did it, I think he was doing 5 or 6 of them that very day. And it seemed like he was the spacer doctor that Duke would rely on. And because I was very skeptical because I got this colitis and was very hesitant for radiation because it could damage the colon. So I was all in for the spacer. But this Dr. Chin who did it, and the other one is I thought it'd be very painful. It really wasn't it wasn't painful at all. And I think he did a fine job. I think he's very experienced at doing it. And I think the level expertise of the physician that does it is going to tell you whether it's successful or not.
Thanks.
Yeah, interesting.
That's all I have, Ben.
Okay. Thank you, Dan. Steve L., you are next.
Okay. Yes, I guess to start, I'm metastatic castration resistant prostate cancer. And my doc a few weeks ago just vaguely mentioned some sort of a treatment with testosterone. and I think someone else mentioned it a couple weeks ago. And now I've done a little research, and it's called bipolar
Yeah, yeah.
therapy. And I'm just trying to learn about it, and was wondering if anybody has experienced it or researched it at all.
So have you seen Rick's comment in the chat?
No.
So do you know how to call up the chat?
Okay, I see it now.
Okay.
Yeah. Oh, okay. Back in 2005. Okay. Now I see it. Now I can go to that later, and I'll just read it later. Thank you.
Um, so it's been around a while. And Ben, was there anything else you wanted to say before I jump in
You probably,
on this?
I probably have nothing to add to what you were about to say, just that it doesn't work on everybody.
Yeah,
Uh,
it's been around a long time, and the person who pushed it the most was Sam Denmead at Johns Hopkins, and he did a lot of work with it with Dr. Antanarakis. And I'll put another link because just recently, when I say recently, within the last year to 18 months, Dr. Denmead and Dr. Antanarakis published a sort of a patient's guide to BAT, and I've got the reference. I'll look for it shortly. It's not what we would call a first line treatment. It's probably a third or fourth line treatment. It's a treatment that's used when you're running out of other things to do. And we've had many men use it here. It generally has some durability. I would say anywhere from like 4 months to 18 months, but probably not more than that. But we've had some guys who just haven't got more than 4 or 5 months out of it. And I'd also say that it's, if you're doing fine on where you are, you haven't done chemo yet, you haven't done Pluvicto yet, you haven't done any of the second line treatments, it's not really something that I would consider. But let me see what Ben would like to add to that, and what anyone else has to say.
The thing that I remember is that while they can't tell if it'll be successful on you, there is a certain class of men who should not be getting that. And I don't remember Antonaraka specifically talked about men who, they're not even candidates for this because the testosterone is very likely to make their condition worse, as you would fear. So, who's proposing to give you this treatment?
Help me with the name. Yeah, you've Dr. Yevzeski at Fred Hutch.
Do you know what his experience is in administering this kind of therapy?
We haven't discussed it that much yet. No.
Did he say why he thought that would be the one for you?
No. It's a little trouble. It's a little difficult for me to get reasoning out of him.
Oh,
Yeah.
But we'll try again.
so
Your
yeah.
wife is more than welcome to come interview. We love it when we have care partners on there.
She's better looking than I am, so there she is.
Oh no, it's great, and we love it. We want you both to attend. I'm putting a link in the chat right now. I think this is the article. I haven't looked, but I think that's the article, A Patient's Guide. I think that's the one that Antanarakis and Denmead wrote relatively recently. you know, let me ask you a question. Have you done any chemotherapy yet, Steve?
No, I have not. And
Oh,
I'm currently just finishing up Provenge. I've got my last third treatment on my third infusion on Thursday.
okay. And where's your reminders? Where's your PSA? And what drugs are you on right now?
Um, just Lupron, abiraterone, and the secondary um, hormone.
Not the secondary hormone, prednisone. Prednisone.
Prednisone. I was on prednisone first, and then when my PSA started coming up, they switched me to a different hormone.
To a dexamethasone, probably.
Yeah. Yes.
Right. So I think the question to ask Yuzevsky is why is he proposing if your PSA continues to rise, why is he proposing BAT rather than chemotherapy? Because one of the things we've learned over the last 10 or 15 years is that chemotherapy is very effective, and the earlier you get it, the better you are. Does anybody want to do it? No, they don't. But it's durable, and not only that, you can repeat it. And as things stand right now, although that may change this year, if you want to get Pluvicto, you have to have done some chemotherapy first.
Yes.
So the question is, what research does he have that suggests that early use of BAT is a good option, and how has he used it in that respect? I think it would be very interesting to ask. John Blanchett isn't with us tonight, but he's a doctor. He's a man who sees Dr. Antanarakis. We sort of know Dr. Antanarakis. He knows us. But the question would be, what's the benefit of using it early? I'm not really heard too much. The problem is it just doesn't have legs, I mean, it's sexy, it sounds good. Oh, you get a big shot of testosterone, and you go off the Lupron, and then you come back on the Lupron. But the thing is that it just doesn't last that long, and you're going to have to do something after it.
So, and it's something that can typically be done later in the series.
Well, I would say that, and again, I defer back to Ben and to any of the other, Len's not on here, but any of the other old timers on here. We've usually seen it employed later in the disease cycle.
Okay.
Ben?
Even by Denmead, the eager beaver?
I'm not sure with Denmead. Denmead may have done it earlier, but he hasn't. But he's published results, and he doesn't have there's no results. We don't see the most I think we've ever seen is like 18 months, which isn't bad. But most of the time it's shorter than that. And maybe if you use it earlier, you get more out of it. I don't know, Ben. I don't know. Jeff, what's your
Yeah.
Well, just another option. I mean, I went from Abby to darolutamide, and my PSA went down to 7 months now, undetectable. And on Abby, I was never that low. You might consider trying Abby or enzalutamide and see if it does that for you. If not, then go to chemo.
Yeah,
Yep.
good suggestion.
Yeah, and I was undetectable for 2.5 years just with Abby and uh, Luprons. So, and then it started up. Most recently, 0.5.
So that's definitely the right. The link I put in, I just opened it, is definitely the right link, and it's an article by Den Mead and Antanarakis and Mark Makowski, all at the time at Johns Hopkins. It's called Bipolar Androgen Therapy: A Patient's Guide. So
Okay.
and it's written with the intention of a patient being able to read it. So and it's from May of 22, so it's 2 years old at this point.
When were you scheduled to start, Steve?
I'm not scheduled to start. It was just
Okay.
vaguely mentioned.
Okay.
And
Okay.
actually, so was chemo mentioned. So, yeah, I don't really have a sequence, a proposed sequence in mind.
Good. So you'll have time to look over the paper.
Yes,
And
I will. Thank you much.
it sounds like he's throwing out options. You're not being hustled into this thing, which is good.
Yep.
So good. Read the paper, and it'll be interesting to see what you think, what he thinks.
Yep. Okay. Thank you much, everyone.
Thank you, Steve. Jimmy G, you have the stage.
Hello, hello, hello. It's hard for me to be concise about this, but I'll try. So I've had recurrent high fever since April 2021, every 6 to 9 months, 104 fever or so, shaking, chills, hideous for about 4 or 5 hours, then it dissipates, stays at low level for a couple of days, goes away, comes back again. Couldn't really find a cause. This time, 2 weeks ago, I went in the hospital because it was real bad. I couldn't stand up, couldn't walk. And I had waited so long to get in the emergency room. 17 hours the first time I went in 2021. I waited 10 hours the second time, and several times I didn't go because I had no faith that I would be able to get in. As they said, you want to get tested, your blood cultures and scrotal ultrasound and stuff. You want to do it while you're still symptomatic. And before, the symptoms had pretty much passed by the time they got around to seeing me. It's a long time. This time, since I couldn't get out of the car, they brought a wheelchair out to the car and then wheeled me in. And I gotta recommend to anybody who wants to has been having trouble getting through the emergency room, if you ever get in there and you want faster service, just get the wheelchair. They push you right past everybody. I always ended up looking too healthy, I think. They put me in the back of the line. Well, my wife went in there and said he needs a wheelchair. They got me right in. Got the blood cultures taken right away, and they were positive for strep B, so they put me on a couple of days of IV antibiotics and then some pills to take home. The newest diagnosis is cellulitis. This is what the latest infectious disease doctor, I would say he surmises it. I guess I would call that, instead of guessing, it sounds more professional. But I think they're really still guessing at what it really is. It was supposedly we thought it was had to do with the artificial urinary sphincter I had installed about a month before I started having these fevers. But the original surgeon said it's not that type of profile for that infection. I sent a message to my original radiation oncologist from 2020, asking me if he's ever had any patients that have had cellulitis after radiation later on. A lot of redness, a lot of swelling in the groin accompanied it. And, the more I find out about it, the more I always kind of, I try to see the humor in everything if I can, but I always like to say now it's unlikely that prostate cancer will kill me, but the consequences of the treatment might. I was, as practically had sepsis this time. And if these come back, I have a pill in pocket, as they say, which is their approach for, so you don't have to go and get antibiotics prescribed and fill a prescription. But I find out that cellulitis can be more susceptible to people who have had lymph node removal. I had 15 of those removed when I had my prostatectomy. I had 35 sessions of IMRT. I had 4 rounds of Texas chemotherapy. So who knows? But the good news is that when I'm not sick, I feel great. I got my labs. I've now about 39 months since full return of testosterone with an undetectable PSA. So the way that I look at things, the way that we look at things, hopefully, is that no matter what might be going on with us, if the disease is, wherever it is, they can't find it. It's either eradicated or it's sleeping soundly. So that's what we want. And I'll continue to try to find out what's going on with fevers, but it's definitely been a medical mystery so far.
Jimmy, when you said 4 rounds of Taxotere, was that 4 cycles or just four times instead of 6 for one
chemotherapy?
Yeah.
It was 4 cycles.
Thanks.
And the first time that I got the intense rash in my groin and did not feel well was on a weekend when I had chemotherapy in 2019 when I first started it. And I had this terrible rash down there, and it went away. And then nothing happened with that. I was fine until April 21. So I don't really know the process. I don't think anybody does. I try to keep it clean down there. I try to hope that whatever's getting in there, it's not. If it comes to the point where I really think I'd have to try to get the urinary sphincter replaced, I don't want to do that. Certainly don't want to remove permanently, but I don't want to think about that until I see if this hard-hitting antibiotic therapy, which they never gave me before, and all this time they never once recommended antibiotics. So, and no one said anything about cellulitis either. So maybe I got a good diagnosis. Maybe I have a solution. We'll see.
Jimmy, how did your radiation, you said you brought it up to your radiation oncologist. Did you hear back from him?
Not yet. I sent him a message, and I think he'll answer. But I wouldn't be surprised if he's never seen it in a patient. I'm trying to look it up. Women who've had breast cancer, radiation for breast cancer, have had cellulitis that I've been able to find, but I haven't seen anything for prostate. But I'm not finished looking, and he's going to tell me what he knows. If anybody has ever heard of anybody that had cellulitis as a result, and they're going as a result of radiation, please speak up, but I'm pretty sure there isn't anyone.
So I think I told you that it's seen, it's not uncommon in other cancers, especially in breast cancer, cellulitis. But we've never run across it in prostate cancer, but it could be. It could be.
I don't know. I mean, I'm just glad that when it hits, it doesn't always hit as hard as it did that day, but it has several occasions. And for those 3 or 4 or 5 hours, it's a little rough. I don't mind telling you. I couldn't stand. I couldn't turn in bed. I couldn't walk. I couldn't think straight. I was shivering uncontrollably, fever very high. And then it settled down after several hours. So, I look at the bright side of everything, except that I don't think I can continue to have bacteria in my blood on the regular every 6 to 9 months and have that as a sustainable model. I don't feel too good about that. And hopefully that's not where it's headed.
But Jimmy, this has been the pattern now for months. I mean, when these fevers come, they're really intense.
Since April of 21.
Yeah.
Yeah.
Since April of 21. So, and this seems like the first time that you've received what might be a plausible explanation. We haven't heard anything plausible before.
No, I'm surprised I've not been prescribed antibiotics till now. They didn't let me out of the hospital for 2 days. It kept me on IV antibiotics the whole time. I haven't been in the hospital for 2 days ever. Even when I had my surgeries, I wasn't in there that long. I had my own room because I had COVID also. I didn't know it was asymptomatic for the COVID, but it got me a nice private room. So I started feeling better right away. I asked my wife to bring me an exercise mat so I could do some stretching on the floor. My brother's a retired doctor, and my wife told her that I had asked for the mat. She says, the hospital is filthy. You can't bring him an exercise mat. That's crazy. So I got nixed on that one.
I did ask Dr. Palla, because I was in correspondence with her on a totally unrelated issue, and she said she's not come across cellulitis with respect to prostate cancer. And she's at Sidley.
I hate to think that he's just, taking a shot, but that's happened before. One of the other urologists, the guy that your guy referred me to, was a real nice guy. He said they put an antibiotic coating on the AUS when they put it in, and you could, possibly be allergic, remnants of that. But he frankly admitted that it was a Hail Mary, that it was just out of left field. No one's had any answers. But the last infectious disease doctor I saw, a young woman, I told her everything. And, I said, I don't know. I mean, it's just like I always feel much better. And the next day I'm fine. And she looked at me and she goes, this is serious. Don't die. I said, well, I'll do my best, lady. What can I tell you?
Hello, Rick. How's it going? Hello, Rick. This is Henry. How's it going?
Hi, Henry. How are you?
Good. I just want to chime in real quick. I recently had a bout of cellulitis. I had 2 bouts of cellulitis, one after my prostate cancer surgery. It was due to the substance that they put over my incisions, and I was placed on antibiotics. My second bout of cellulitis came from my surgery when I had a pacemaker. And that's the way I found out that I'm allergic to whatever substance is that they place over your incisions, the plastic to cover up the wounds rather than use stitches. They use a plastic covering to just cover up the wounds. And I had 2 bouts of cellulitis just from the substance. Possibly you could be allergic to whatever it is that something is made out of, and it's causing you to respond like that. That's what happened to me anyway.
Thank you.
Yeah. I mean, I have enough experience with cellulitis too, but it's not radiation related. So I'm very empathetic, and yes, it does give you a fever, and yes, it makes you pretty miserable, but I know in my case it wasn't the 2 times or 3 times that I've had it. It's not had anything to do with radiation. And that's the issue with you, which is it does seem to be radiation based, and the fact that it keeps coming, it keeps recurring, would sort of suggest again that it could be related to the radiation, because if you've got radiation cystitis or radiation proctitis, which is just another form of radiation inflammation, it comes and it goes. It doesn't go, it's not like a one-time incident. Most of us who have had radiation cystitis or radiation proctitis have dealt with it repeatedly. Yeah. So, this is a form of radiation inflammation somewhere. Could well be.
Or the lymph node removal. Are lymph nodes still routinely removed 10, 15, 20 of them at a time when someone has a prostatectomy? I would think that that's, you know, on the way out with sensitive scans. When I had my prostatectomy, PSMA was not available. So that's when they would, you know, part of their pathology.
Well, it was available, but it was available in trial at that point in time.
Yeah, well, I mean, I couldn't get it
anyway. You know, it probably was available. When you say you couldn't get it, it probably was available through Hopkins, but they never offered it to you, which is what they should.
The Bear had no interest in it. I had heard of it.
So there you go. The Bear had no interest in it, so you know, because he wanted you in that trial. So, but yes, I mean, I still think I don't know enough about current surgical techniques. Maybe somebody else on this call does, but I do believe that they still remove a lot of lymph nodes.
I think they do. I've got orchitis down there too, so it's taken a beating. My right side epididymis, orchitis. So there's been some real it's scorched earth down there, and I feel good most of the time, but I don't know. I do what I can. So that's enough of me. I feel great today, guys. Just know that, just for the record. I'm gonna get a CPAP. Oh yeah. I've had apnea for years, I think. I took that overnight sleep test. They put that apnea mask on me. Man, I felt like it was breathing for me. I didn't think it was uncomfortable at all. I think that's how you know if you can use one or not, because people look at pictures of them and think, how in the world could anybody wear that thing? But if you've had enough sleep deprivation and it works for you, you take it with you like a pet wherever you go on vacation. My retired doctor brother says everybody he knew that used CPAP just either absolutely loved it or they refused it outright after the first couple times. Most people, he said, liked it. Anybody
here? Jimmy, I got a great idea. Maybe they should strap that CPAP to your groin.
Yeah, easy now. I'll get that. Let's see if I can find that radiation tech. Have her do it.
Well, you know, because it's like the chambers, what do they call them? The hyperbaric chambers. You know, where they put more oxygen into the tissue, and it helps it recover. So maybe we should put
okay. You know, take that one on the road. Get me out of here. Move on.
Jimmy, I've been using a CPAP for 1 year. I never thought I had it, but it certainly helps my heart because I wasn't aware it was driving my atrial fibrillation 13 years ago where I should have put a CPAP on. And I didn't think I was a candidate because I'm thin, I don't have a fat neck and all the other things, and just like you, I imagine. But I'm telling you, it certainly makes a difference. I'm not as comfortable as you are with it. Do you use a full mask or just in your nose?
Well, I was comfortable with it for the one night that I sampled it. Check back with me when I've worn it for a while. But you're okay with it?
I'm mixed. You know, I prefer getting up in the morning and having an hour of sleep without it. It's my preference because, you know, nothing like cool air rather than warm air rushing in my nose all night. And, you know, I like cool air conditioning a lot better. But, you know, I've learned to live with it. And, you know, I don't want to take a chance on messing up my heart rhythm anymore. And I had no idea it was driving my arrhythmia. But I'm not crazy about it. If I had my druthers, I'd go without it. But
I can understand. And I'm habituated to wake up every 45 minutes to an hour anyway. Mm-hmm. I'm lucky if I get an hour of sleep, an hour and a half of sleep at a time. Mm-hmm. I remember when I first came on the group and I said, guys, I'm only sleeping for an hour and a half at a time. This is hell. And everybody's like, welcome to the club, man. You know?
Yeah.
It's just very common for us.
Yeah.
So no whining to me.
I tried a CPAP and could not even begin to sleep with it. I have my minor issue problem, so I don't really need it. But boy, I couldn't. There's no way I could go to sleep with that thing on me.
Understand.
Okay. Thank you, Jimmy. I hope the CPAP will get you some rest.
I just
Andre, you're
wanted,
up. Oh, yeah, sorry. Go ahead, Mark.
no, I just want to add, I couldn't handle the CPAP machine, and I got a dental sleep solution, which is like a retainer that holds your jaw forward, and it works great for me.
There are alternatives. Yeah, but keep in mind. Thanks, Mark. I know there are alternatives that are not so invasive.
Andre, you're up next.
Yes, probably a rather mundane question because I'm just beginning my journey on the ADT. It's been 2.5 months, month of Casodex and a month and a half of Orgovitz. But I'm wondering if I used to have to get up 3-4 times a night to urinate. And since I've been on the ADT, I'm sleeping through the night. So I'm just wondering if that's an unusual thing, if that's an expected thing, or is it something else? Anybody's experience with, because I've got another couple weeks before I do the brachytherapy and then the radiation. So I don't know. Kind of curious if this is a result of being on the ADT.
Well, if anything, I think most people would tell you that the ADT interrupts their sleep, Andre. So you're doing great. Now, there's a couple of things. One is ADT takes time to hit. So but you are using Orgovix, you said, right?
Yeah,
So
yeah.
it's more immediate than if you were using, say, a Lupron or something like that. That said, the reason it interrupts your sleep is because a lot of people suffer from hot flashes, and the hot flashes wake you up during the night, and you don't even realize you're being woken up. So you wake up in the morning like a Mack truck hit you, and you don't even understand why, and that's pretty common. I don't know of anybody who has had their sleep improved by ADT, but there's always a first. So
I appreciate the input because I just thought it was kind of strange, but I had to ask. I know the space org topic came up a little earlier, and I'm planning on having that done while I have the brachytherapy. And the oncologist showed me a picture of the MRI, and he said there's enough space between the prostate and the rectum that he would be able to do it, but it's not always possible. And the other oncologist I didn't go with was concerned it would hide some of the uh, cancerous material. I'm presuming that's maybe if it's too close to the rectum. So that's just a little aside. I haven't gone through it yet, but I plan on having it in a couple of weeks. So that's
Andre,
all.
did you say that you had to pee all night, and once you started the ADT at some point, you were able to sleep through the night because you didn't have to pee, get up and pee?
Yes, yes. It's not
So
hot flashes, but it's just the fact that I had to start getting up. I've been doing that for quite some time, and then I got, diagnosed with prostate cancer.
how
Uh,
long after the ADT did you stop having to get up to pee?
I'd say within 5 weeks or so, a
All
month.
right. Well, I don't know. Did you have a big prostate to begin with?
It's enlarged, but I didn't think it was. I don't think it's considered, very enlarged.
Well, I don't know to what degree it was enlarged, but theoretically, if you had a somewhat enlarged prostate, which was contributing toward you having to get up at night to pee,
Mm.
some shrinkage would occur with 5 weeks of ADT, I assume, and that could have allowed you to have some normality to your sleep and without having to get up and pee. So that's my guess, just
yeah.
from a common sense point of view.
That's a great
Okay.
thought.
Well, I appreciate that. I hope after the brachytherapy, all things don't change, but we'll see how that all goes. So, thank you.
Thanks, Andre. George Wesolowski, you are next.
Jim Marshall had his hand up on
Oh,
that
I
issue.
beg your pardon, Jim. You did
Yeah,
indeed.
Andre, are you going to have um, the high dose or the low dose?
High dose.
High dose. I sort of thought so. Okay. Thank you. I was curious.
I just wanted to say, I really like Dr. Jack's suggestion. I mean, it
Yeah.
could be that it could have been the cancer, it could have been the size of the prostate, but the tumor could have been putting pressure on your urethra and making you want to go, and the 4 or 5 weeks of hormone therapy with Orgovix, which is going to have an impact right away. Could have taken that pressure off of your bladder. So that definitely, there's definitely a correlation there.
I kind of thought so. I appreciate it.
Thank you. George, you're up next.
My question is a drug called solifenacin. I have been, like you all have been saying, getting up every hour and a half to pee, never getting a really good night's sleep. And my endocrinologist recommended this solifenacin to retain water. And immediately when I tried it, I was amazed. I could get 3 hours of sleep and go and pee maybe only every 2.5 to 3 hours. It's really helped me get to sleep. Has anyone ever heard of solifenacin? I was surprised that no urologist had ever mentioned it. And here it was my endocrinologist who came up with it and said it'd be worth a try. So I take one tablet before I go to bed at night. And I thought in the morning I probably would weigh an extra few pounds as I'm retaining water. That's really not the case. I really haven't gained any real weight whatsoever, but it sure has helped me get a restful night's sleep.
Could you spell it for me, George?
Yeah.
I can't seem to look it up on SOLU.
SOLI. Sorry.
SOLIFENACIN. Solifenacin. I'm looking it up right now. It's a bladder relaxant.
Thank you.
Right.
Vesicare.
Really has helped me get a restful night's sleep.
It's an anticholinergic, an antimuscarinic.
So there are a couple of other drugs like that we are aware of that have been prescribed, but this one we haven't heard of before. I'm trying to remember the name of a couple of those, the other ones, those that take away the spasms for urgency.
The oxybutynin it ranks a bit higher.
Yeah, oxybutynin is definitely one.
Tellulosin,
right,
which I took for a while. It really didn't do much at all, even at a higher dose. So I stopped taking it completely. Tamulosin.
Tamulosin, yeah, but that's an older drug. Tamulosin is a much older drug. Just trying to think of it begins with an M.
Mirabegron.
That's Merbegron. Merbegron is the is the one that I was thinking of, but we'll suggest this one along. I think Merbegron is also. You have your hand up, Mike. You wanted to say something on this one?
Yes. Can you hear me okay?
Yes, great.
Okay. Yeah, Are we talking about the medication that's spelled SOLIFENACIN?
Yes.
Yes.
Okay, I am taking it. I didn't really realize it. And it says take 1 tablet by mouth daily for bladder spasms. So what my issue was which I know most people don't have any radiation issues for 2 years or 3 years, but I did, and I think mine was been over about a couple of months ago, my last treatment. But I had burning urination frequency. So I went into see my urologist, and I was prescribed that. Now, I think what you were saying, you were prescribed it to not urinate as much. Is that what you were saying?
Yes.
Okay. So mine was for that, for bladder spasms, and it works terrific. But if that helps with that as well, well, that's great. I didn't even realize that I was taking it until I looked at it here. I mean, the name of it. I knew I was taking it, but I didn't remember what the name was. So, and it works great for what I need it for. It works great.
Hmm.
Okay. Yeah, it's interesting that with all our experience, we had not heard of that one.
Well, now there's 2 of us.
That's
Yeah.
right.
Yeah.
Okay, John Io.
Hi, team. So just a quick backtrack. I'm relatively new to this journey. So May of 21, well, I was diagnosed with prostate cancer Gleason 8 in October of 20. And I did a prostatectomy May of 21 and undetectable until this, May a year ago. And then it started to go up, and then it went up to PSA went up to 1.7 in November. So I did a PSMA PET and showed metastasis. So I got on Nubeqa as a monotherapy in January, and PSA, went to like 0.5, and then it went to 1.04, and then it went to 1.6, then it went to 4.9 in May. So I got on Orgovix. So started the Orgovix on May 22nd, and I just had a blood test last week, so July the 1st. Orgovix did its job. Testosterone went from 562 to less than 3 in a month. PSA went from 4.9 to 35.4. So that's my first question, is how odd is that? And so, what Dr. Wong has suggested, and what I'm doing finally, is the genetic test. I've already done the germline, and we're doing the somatic now to see what's going on with that, and then scheduling another PET scan to see what's happening. But I feel good overall. Just had I don't know, all of a sudden the last few days my shoulder has started to hurt, which is weird. But there you go. So that's kind of the overall. So have anybody seen a PSA spike like that getting on Orgovix?
No, but what it's telling me and is that your cancer is not an adenocarcinoma.
Yeah.
In other words, it's not sensitive. And
Well, the biopsy was adenocarcinoma on the biopsy.
yeah, but things can change.
Okay.
I mean, you originally started on Orgovix plus Daro, right?
No, just Daro monotherapy.
Oh, so you'd never taken the Orgovix until you just started. Okay.
Yep.
It sounds to me, and it happened, it's not sensitive, and I think that Dr. Wang should be maybe looking for other signatures. not just the sequencing. Did he sequence you with blood or did he use a solid tumor?
Blood.
So, and who did he send it to?
I believe Guardant.
Yeah, you don't want to go to Guardant. Have him tell, Tempus, Caris, Foundation Medicine, but Guardant is probably the least reliable of the lot. They're just not good. And we've come across this all the time. So if it were me, I would not be going there. I would have gone to Tempus.
Is there a way to change that at this point? Just have to do another test? Because it's like $9,000 to insurance, right?
Well, they don't pay that much, but it's expensive. But it's just that the Guardant test is not a great test, and the doctor shouldn't be using it. And we've got doctors that we work with who have found that out. We've also had people who have gone to Guardant and then subsequently gone to Tempus or FMI and come back with different results. So, we're just not fans of Guardant. And I don't know what to say to you other than to tell you that we have had experience of unreliable results from Guardant, which is why we generally send people. I mean, I think our preferred test right now would be probably Tempus, followed by either FMI or Caris.
Yeah, I just don't know if insurance is going to pay for 2 genetic tests back to back.
Genomic tests. I don't know. Yeah, I don't
Gotcha.
know.
Okay.
So Rick, are we talking about false positives as well as false negatives? In other words, if he sees an actionable mutation, isn't that good enough?
The problem is that it's going to miss stuff.
Well, yeah, certainly if he.
So
Okay.
that's not a false positive or a false negative. What's that one? That's specificity. Is that sensitivity or specific? How about giving us a little lesson on sensitivity and specificity?
So the gene panel is insufficient. Is that what you're saying? It doesn't look at enough genes?
It doesn't catch everything. I mean, we've known people that have. It's supposed to be on the gene panel, but it hasn't caught it.
Okay. Back to this cancer. It's right. The stuff we think about that isn't adenocarcinoma tends also not to generate PSA, but there's plenty of PSA in this case. Oh, I was hoping you'd leap in, Rick, and say, "Oh yes, well we know about that. That's an XYZ."
I don't.
Yeah, John.
What I am thinking is, I mean, this is a real puzzle, and I think what I would do, especially based on them Wang going to Guardant, is I would get your results and I would think about a second opinion, John.
Okay.
Dr. John.
All right.
Yeah, and the other Dr. John, and your fan's not on again. You need to put that fan. How do you live in that house in Tucson without the ceiling fan going, Dr. John? I know. You know why? Because I told him it was going around the wrong way yesterday, and he hasn't checked it out. Because ceiling fans are supposed to go clockwise in the summer and anti-clockwise in the winter, but he hasn't checked it out yet. So now today he's sweating there, and he hasn't put it on at all.
You absolutely got me right. Yep.
Well, even if it's going the wrong way, it's better than it not going at all. Go ahead, Dr. John.
It's sometimes when we get a lab result that seems way out of whack of clinical findings, we just simply repeat it. Every now and then you just pick up a lab error. Maybe the PSA is an anomaly.
Yeah. I don't know. It's never really, clicked in. The highest it ever got was 12 with a Gleason 8 back when I originally was diagnosed. So it's never really tracked. And then, of course, it went undetectable for 2 years. And I don't know. Does that indicate I mean, so that certainly is an option, Dr. John. Thank you. It could just be a lab error. I mean, and I need to just go get another test here in a couple of weeks. But would you guys continue on with this? Because I've heard good stories here from you guys on darolutamide and Orgovix together.
Sure.
Would it make sense for him to get another, at this point, to get another biopsy? I'm sorry, to get another opinion on his biopsy?
Well, I think what I would do is get these results. Now, if we send Dr. John down to Eleni, she won't look at that Guardant report. She'll order a Tempus report, and she'll be able to justify it with your insurance, because we've seen her do that before. Don't ask me how she does it. I couldn't tell you, but rather than, if you're thinking of doing that, then I wouldn't even bother taking it up with Wang, because it's controversial. Guardant's controversial, but go down to Houston, go see Eleni, and if there's something weird going on, she would be one of the few doctors in the country that I think might be able to spot it. And, fortunately, it's not a huge way for you to go if you had to go to Houston Methodist.
Right.
So that's a real option, Dr. John.
Okay.
But the first thing is, let's see what this comes back with. Some of the results that we've seen unreliable have been in either, and I can't remember which, either in tumor mutation burden measurement or in MSI measurement. Those I think have not been that reliable, or they didn't measure one, or I can't remember, but I seem to think it's somewhere around that. But it is weird. I would get, when was this last PSA?
July 1.
If it were me, I'd run it again this week for confirmation.
Okay.
I mean, there's doesn't hurt to get another one, and something else completely might be going on, and just come back and talk to us. And that Guardant test should be back within about 10 days, and tell us what that says. You can send it to us. We'll take a look at it, and then we can talk to you. But it is a concern to me that you add the Orgovix, the testosterone. Your testosterone drops from 500 plus to 3, and your PSA goes up to 35. I mean, it's weird.
It's very weird.
Do you still? I can't remember. Do you still have a prostate?
No, we removed 3 years ago.
Oh, wow.
Okay. Oh yeah, I see it.
And I've got, we scheduled a PSMA PET scan for August 6th. Just to, because the last one, the first and only one I've done was December 1st of last year.
And did it show anything?
Yeah, it showed metastasis to, bones and a few lymph nodes.
Okay. I mean, that's important, because we know that you were producing PSMA last year.
Yes.
And I see that now in my notes. So if there's something weird going on,
that doesn't rule it out. I find it really, it doesn't seem like just an outlier PSA. It seems like a pattern of not responding to ADT. And
Mm.
and I if Dr. E is an option, I would see her case closed.
What is her name?
Go ahead, Ben.
Somebody will be kind enough to put it in the chat. Eleni Estafiou. Yeah, you made me say it.
Yeah.
She's born in Greece.
Okay, I'll look for it in the chat.
Yeah, I'll give you a link. I'll give you a URL in the chat.
Does anybody have
her name is
pain?
pronounced Dr. E.
Dr. E. Anybody
That's
have
the
pain from getting
pronunciation.
on Orgovix? Just started like a few days ago, so it would have been like a month in, 5 weeks.
What was the question?
Pain? Any like I said, my shoulder all of a sudden just started hurting the last few days really bad, and I've
No
never
pain.
had that before. So
Yeah, I've got no pain.
yeah,
No pain
but
here.
okay. But I did notice for the person that talked about sleep, once I got on the Orgovix, I did have a little bit of pain in my leg. It went away, and I started sleeping much better with Orgovix. So another odd thing.
You're not on a proton pump inhibitor, are you?
Yes. No, not a proton pump. No, not a proton pump. No, I'm on a Prozac.
Okay.
SSRI.
Okay, because we do know of bad interactions between Orgovix and proton pump inhibitors.
Right.
You heard it here first.
Yeah. Yeah.
Okay, well, I will find Dr. E and see if I can't get another blood test, second opinion on this Guardant thing once I get it. But I'll come back on and let you guys know what we see.
Rick,
Yeah.
that's an interesting theoretical idea you're presenting, that maybe there's a competitive thing going on between the enzymes in the liver. I don't know what all the drugs are that he's taking, but if you're taking enough drugs, you really have to check out and see whether or not there's anything that's competitively going on between the drugs you're taking and the Orgovix, because it could be causing an elevation of your PSA. Paradoxically, if the PSA is being augmented by the drug that you're taking.
Yeah, that's the only other drug. Those are the only 3 prescriptions that I take. A lot of holistic herbal supplements.
Right.
Well, yeah,
so I was just going to ask you about that. So, are you taking American ginseng?
No.
Shit.
I take milk thistle. But my liver, my AST is 42, ALT is 46.
It started at 6.
So, one of the things we've learned recently is that certain supplements like American ginseng, and I think there are others, but this will be easy for you to research, Dr. John, because it's your area. They can work through the CYPA3 pathway.
Okay.
And if they do, if any of your supplements work through the CYPA3 pathway, then they interfere with the darolutamide, and it changes the dose of it impacts the dosage. So the dosage isn't, I'm not saying this very well, but the dosage isn't true compared to somebody who wasn't taking it. Okay, so if you're taking anything that uses that if you're taking any supplement that uses that CYPA3 pathway, you need to be careful. This is something also that we found out with oxybutynin, This was why you couldn't use oxybutynin if you were on one of the Ide brothers, because oxybutynin interferes with that CYPA3 pathway.
And interferes with the Dara?
I'm sorry?
It interferes with the darolutamide, you said?
It interferes with darolutamide, enzalutamide, and apalutamide, any of those three, because all three of them use the CYPA3 pathway.
Okay.
And then we found out last week, I did some reading, or I think I got a note on American ginseng from Memorial Sloan Kettering, and that uses the CYPA3 pathway. And I think there are other supplements that may use it. So just make sure that none of your supplements are competing with pathways that your drugs are using.
Okay. Is it time to part ways with Dr. Wong and go see Dr. E? Do you switch, or do I just go to her to get this test?
I think you go to both of them and then you decide what you like. Okay. Where do you live in Dallas, or do you live?
I do.
Oh, you live in Dallas. So, it's...
Is Dr. E okay with telehealth?
Yeah, she's fine with telehealth, especially since you're in there. But I think you'd need to go see her the first time.
Okay. All right, I'll give her a call, and I'll get back with you guys when I get the Guardant results.
Her staff is there this week, but I happen to know she is not there this week. She had a family medical emergency, and she's leaving for Greece tonight.
Oh,
so,
okay.
But she expects to be back within 5 days. But try and get on. Call and make an appointment. By the time you get the appointment, you'll have the Guardant results, and you'll set it out 2 or 3 weeks. You'll have the Guardant results, and she'll be back.
Okay.
Jim, what say you?
Excuse me. I believe that is the CYP3A, not the CYA3.
You could be right.
CA.
I looked it up. Okay. So
3A4 to be specific for darolutamide.
CYP, that's right. Sorry.
3A4.
And to be
CYP
even more specific,
3A4.
P450 CYPA34.
I misspoke, but the message is still the same. Make sure that anything you're taking doesn't use the same pathway as something else you're taking, particularly if you're taking one of the Ide brothers. That goes for everybody. Who was it that was telling us they were going to start taking American ginseng to make them feel stronger, to fight fatigue? A great idea, but don't do it if you're taking enzalutamide, darolutamide, or apalutamide.
David Muslin, you're the last official speaker of the meeting.
Okay, last official. So let me give you some data, and then I'll ask my question. On September 9/23, I took a drug holiday. Have had no PSA at all, undetectable. On early April of this year, it went up to 0.1. End of May, it went up to 0.21. And by June 21st, it went up to 0.25. On June 29th, I had a Pylarify test, which came up clean. Rick knows all this, by the way. Came up clean, and Shmulewitz says, "Come back in 3 months. We'll see what's happening then. Go enjoy your summer." But in the meantime, I had on my calendar today to go do a blood test next week. And the question that I asked myself and I asked the group is, do I get a blood test in 30 days and just slowly watch it go up? Or should I just put it neutral, enjoy the summer, and deal with this in September? That's the question.
Sounds like you know what you want to do, David.
I know I don't want to make myself crazy, but am I being foolish by taking that type of approach, waiting waiting until September. September now is 2 months. So
I'm surprised Jim Marshall's hand isn't up already.
What?
Don't you do your PSAs every 30 days?
he
Oh,
does.
yes.
He
Yes.
does. But I don't want to make myself crazy either. But am I being foolish by not doing it in 30 days and just slowly watch it go up? I guess I can answer my own question, but I just thought I'd throw it out to the group.
2
Rick
to
is
2.5 isn't doubling. That seems to be a slowing
one.
rise.
Yeah, 1.8 months is a doubling time.
Well,
Do it in
but you went
60
from 2
days.
to 2.5 in 30 days, right?
Went from 0.19 to 0.25 in less than 30 days, roughly. About 21 days to be exact.
So David, what's the number inside your head that's going to make you so uncomfortable that you're going to want to go back on
Well,
darolutamide?
I think, that's a good question, Jack, because Shmuel always looked at me and says, do you want to manage the PSA number or do you want to manage metastases? And I'm enjoying life so much being on a drug holiday. I said, I'd almost rather wait. And if there's a couple of Mets, let's blast it and see what happens after that, because I've done that before with 2 Mets on ribs. So I think I'd rather manage that than go back on ADT right now. And I know eventually I'll have to go back on ADT, but I'm going to try to enjoy every day that I can. So I guess I'm kind of answering my own question, but just wanted to get the
Sure.
input from
Remember, I
my
just
guy.
reported last week that metastasis-directed radiotherapy can save you some time off ADT.
Say that again, John?
Metastasis-directed radiotherapy can spare you some time from ADT.
Yes.
According to what we reported last week.
Yep.
What made him decide to use a PSMA rather than an FDG scan?
It's interesting. He says Pylarify is a form of
I know.
PSMA.
Yeah, but I guess I'm curious why, why not? What prevented him from doing an FDG rather than a PSMA? With such a, I know you've had metastasis and therefore maybe, it'll always be there with PSMA, as Rick talks about often enough. But I just wonder about this FDG because that seems to be the thing on the horizon that I would do next if I had an elevation in my PSA. At least that's what I've been told, but I'm curious. Maybe Rick, you can educate me about that.
I think the man to educate you is Mr. Nathanson, because he just sent around a paper to the Brains Trust saying that the Pylarify, the 18F, is a little bit better than the gallium-68. And maybe you can put that in the context of when to do the FDG, Mr. N.
I'm sorry, I don't know I'm not. I don't understand, Jack, why you said FDG. Why you think that's the choice for now?
Well, I've been told that the point at which my PSA starts to elevate, that's the test that they would do. So that's the reason I'm asking it. And, I guess maybe they'll change their mind, or
In general, certainly young prostate cancer doesn't show up in an FDG scan because it doesn't have the Warburg effect metabolism.
I know, and I didn't.
Yeah, so I'm surprised. Heavily treated metastatic, castrate resistant will show up on an FDG scan, but I don't know when it would be preferred, unless you're PSMA negative, and then you want a concordant scan.
It's interesting. Okay.
I mean, for you, Jack, maybe it's because you've had such a tough time seeing your metastasis on a PSMA scan. And so that might be the consideration in your particular case. But I think by and large, we would say to folks, see what you can see on a PSMA scan, because because you're more likely to see the cancer on a PSMA scan, but then advised that they should get an FDG scan at some point, certainly if they're going to do Pluvicto. I mean, that we want to make sure you're concordant. But I think for most people, they'd be looking at a PSMA scan over an FDG scan, at least initially. Now, what I thought you were going to say, which is more controversial, is this whole body MRI, which a lot of the doctors are prescribing right now. And I think that's probably a lot more controversial. You're going to see something on a whole body MRI scan that you would not see on a PSMA scan. And there are some doctors who think you do.
Which
And
I've
there are
had
other
too.
doctors who think a whole body MRI scan is a bunch of hooey.
Yeah. I've had 2 total MRIs, and the rationale was to dig into my bone marrow to see what's going on inside the bone marrow, looking for, more metastases that then showed up on my PSMA scan.
Mm.
I had always understood that MRIs doesn't penetrate the bone. Is that incorrect? Am I wrong about that?
What are you saying? I didn't
I'm
hear.
surprised that it could image your bone marrow because I didn't think the MRIs penetrated bone.
Oh, I didn't know either, but that seems to be the belief system some doctors have.
Live and learn.
Mm-hmm.
Okay.
So I guess the end result question for me, or the answer for me, is it's really a personal decision, and I'm not ready to jump on treating the PSA right now. I'm more interested in enjoying the rest of the summer, and I'll deal with it in September. So I'm not going to do the test. I'm going to wait.
Makes
I'll
a lot of sense.
see you out on the ocean.
Yeah.
Yeah.
Thanks,
Yeah.
everybody.
Yeah. How often do you get an opportunity like this, as you were saying,
Right.
to be clear of ADT and actually get your life back a little bit?
Yep.
Yeah,
Thank you, Jen.
we were gonna suggest you pull in Boston and take a quick trip to see one of our gents at Dana Farber. If you need some quick treatment, we could arrange it.
I know we can go anywhere. So thank you, Rick. May take a few days to get there, but it'll all good.
There you go.
Start the
Yeah,
boat, rent the car.
yeah, yeah.
Thank you, everybody.
Thanks, David.
Thank you, Ben.
So, Rick, we have a few late starters. People who came in after
Excuse
we
me,
went.
Ben.
Yeah, I'm sorry. Once
I
again, I
got a
missed your hand.
question
I'm sorry, Jim. Yeah.
back on. It seems last year I had heard that the 68 scan was a preferred one because you could get, I believe, a second read on it very easily. So how would that play into the 2 scans? Do you recall that?
Well, I do recall it, and the problem in the past has with the Polarify scan has been that it doesn't necessarily, it shows too much and you get false positives from it. But this study, and Ben will have to correct me if I'm wrong, I think what they did is they compared people that got Polarify to people that got the gallium scans, and what they found was that people who got the Pylarify scans had a longer period to biochemical recurrence, I think it was, or it was either biochemical recurrence or radio-free progression than the people who got the gallium scans. Isn't that what the study said that you sent around?
I mean,
Then
I just glanced at it so everybody could seize on it. I did not read it closely. It seemed to me, just to be in the context of which of these is good for uh, um, scanning people for purposes of lutetium. that this was all in the context of lutetium, and that they're equally good. That the lutetium label says you have to use gallium-68, but that Polarify is just as good for that purpose.
Yeah.
I didn't realize it made other claims.
I think it did, but I could be wrong, or I could be mixing it up with something else. But whatever it was, it wasn't a huge difference, and it didn't seem to. And I couldn't possibly understand why, but I think there was something in there about the fact that the time, maybe it was after the completion of the Pluvicto treatment, those who were screened on Pylarify had a longer progression-free period than those, but it was like a difference of a couple of months. I mean, it didn't make sense to me why, but don't shoot the messenger, okay? Ben will look at it again and report to
Yes,
us
I will look at it again.
because he's the culprit, because he's the one who sent this out to everybody. So he has to look at it harder. Okay.
That's right. Muddied the waters.
Dr. John, did you look at that? Did you look at that paper yet that Ben sent us?
So far, what I've done is I printed it out. I dug up my old papers that were relevant for comparison, and they're sitting there waiting for me to compare one against the other.
Okay. Well, Len will be back next week. We'll talk about it next week. Mr. Lou, you have your hand up.
Let's see. Can you hear me?
Yes.
Oh, okay. Hi, guys. Yeah, I don't know why my name's coming up that way, but it is. I'll see if I can figure out how to change it. My name's Jeremy, and so I think I am just briefly. I'm a post RPP, about 2.5 years. Undetectable PSA, rising PSA recently within the last 3 months to 0.17, and then 0.16 it was redone, and had a PET scan with this Persloma contrast material, which I guess is a PSMA, which came out negative for any Mets. And so I just literally, the reason why I'm late, I was actually on the phone with my urologist, and he said that he wants to get me in a clinical trial on a different PET scan in the next 6 weeks. I'm not sure what that is exactly, but and take another PSMA, another PSA. But in the meantime, thankfully to AnCan and Rick and our friend Dr. John Morley, is it? Well, thanks to AnCan, I got into Dr. Keyshawn next week, telehealth, and then August 4th into Dr. Reddick at UCLA. And so they'll take a look at what we've got and go from there. I guess it's kind of too early since they can't see anything right now.
Yeah, well, I think it was Mark Perlow that helped you,
Mark Perlow, yes, Mark Perlow, yes. Sorry, yeah.
Who Dr. John and I are going to have breakfast with tomorrow morning, so we'll thank him for you.
Yeah, nice to have friends in high places. So they got me in.
Well, yeah, I mean, Kishan's the man. So, we felt it was more important that you see Kishan initially, but in the long run, Dr. Reddick's the person to run your care.
Yeah.
And so it's all good.
Yeah. So that's where we're at. I don't know anything about this other PSMA scan that they want me to, and they also want me to get an ultrasound. So I don't know what good that will do, but that's where we're at.
Well, just, I mean, the only thing I would say is just make sure you know what this scan is, and make sure that your insurance is covering it, because there may be other tests, and you know, one of the problems with clinical trials is that they don't cover all costs, and people don't
Right.
realize that. They think, oh yeah, I'm good for this, good for that, and then all of a sudden you get hit with a whole bunch
Bill.
of
Yeah.
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 So
Sure.
you know, you've got to be careful on that one.
Sure. I will.
Yeah. Excuse me one second, Mr. Wood. What group were you looking for? I see you just came in here.
The active surveillance. That's the group that I think I'm on.
That is tomorrow.
Okay.
At 8 o'clock Eastern.
Thank
Tomorrow
you.
at 8 o'clock Eastern. This is a different group.
Cheers, and may the
Okay.
force be with you.
Thank you. We've got three groups. We've got three groups overlapping right now. So you've got to ask everybody if they're coming into the right group. And hey, look at that. Dr. Jeff arrived, but it's late. Dr. Jeff, you just came in. What's going on? We missed you.
Unfortunately, I lost a dear friend today,
Oh, I'm
and
sorry.
I was dealing with that loss and contacting. We all grew up together, went to high school together, played a lot of b-ball together, and he passed away. And I just couldn't leave
I'm
that.
so sorry.
So sorry for being late.
Sorry,
So
we
sorry
wish
to
you
hear that.
comfort, and you know, may his memory always be a blessing, Jeff. And sorry to hear it. It's been an interesting group, Jeff. It's probably worth a listen. It's probably worth a listen on the recording. There's been a few different things we've talked about, and a couple of real posers that we don't have any solution to. So, and this will get posted in due time.
I can guarantee it because I'm the one who has to do the posting.
Well, if you've got too much on, I'm happy. I can help you out.
No, happy to do it. Happy to do it.
Okay.
So I don't know what protocol is, of course we're overtime, but a few people came in late, and I would certainly want to ask if they had anything urgent that they had wanted to share. Henry, Michael McCabe, John. I don't know if you had something you wanted to share, and Lou, of course, you just had a chance. So anybody who didn't get asked for time, want to use it now? Last call. Okay. Then I'll wrap it up. Thank you, everybody. Good to see you again.
Thank you. Good night.
Thank you, Ben. Good job. Thank
Great
you.
job.
Everybody. Thank you.
Good night.